So we are recording now. Hello everyone again. My name is Melanie Carminati. I am a physical therapist and owner of Inspira Physical Therapy and Pilates in New York City. We are in for a treat this evening because we are going to be speaking about craniocervical instability, also known as CCI, and we have Dr. Arthur Jenkins with us, neurosurgeon, as well as Dr. Jason Siefferman. So we will be starting off this evening with Dr. Siefferman taking us through CCI, and I am going to share that PowerPoint momentarily. Please, again, keep yourself muted if you are with us and keep your video off. At the very end, we will have time for question and answer, for which we will stop the recording. So if there is anything that you're a little hesitant to ask questions about, don't worry. That will not be recorded and it won't be shared anywhere after this live event. But the recording and the presentations themselves will be recorded and they will be emailed out to you after we have time just to edit the video a little bit and then send it back to you.
Hello, thank you all for joining. I'm Dr. Jason Siefferman. I'm an interventional physiatrist. I treat a lot of hypermobility, headache, and pelvic pain. And by no means is this going to be an extensive or exhaustive overview of craniocervical instability, but it's going to be a brief introduction. We're going to sort of look at some of the main characteristics, the main symptoms, and talk about how we approach this as a diagnosis. And we will have plenty of time for questions at the end, so take notes if you want to ask anything. The best part of these webinars is the conversation we get to in the end between everyone participating and the specialists involved. So first of all, what is CCI? So CCI is instability where the head or the cranium attaches to the neck or the cervical region. And what's separated here at the very top is the cranium, the base of the cranium. Just below that is the C1 vertebra. And just below that is the C2 vertebra, which here is connected to the rest of the spine below. So you can see the OA or occipito-atlantal joint at the very top. And then just below that, where the C1-2 or the AA joint articulates. And these are the joints that can be hypermobile in CCI. What causes CCI? At the core, it's inadequate bone structure or ligamentous integrity, loss of ligamentous integrity. This can happen with trauma, such as whiplash, fracture to the neck. It can happen in autoimmune conditions. We see this with rheumatoid arthritis or some of the seronegative spondyloarthropathies where there's autoimmune degeneration of this tissue. And we see it in hypermobility spectrum disorders and Ehlers-Danlos Syndrome. And of course, it can be more than one of the above. It's not uncommon. We have patients with EDS who had whiplash or EDS with autoimmune. What are the symptoms, or at least some of the symptoms, the more common symptoms of CCI? Because I don't know that we even have an exhaustive list, an all-inclusive list of these symptoms. I don't know that that's been conclusively mapped out yet. But the things that we do commonly associate with it are headache and more than one kind of headache. And part of the intake, part of understanding what's going on is looking at the different headache qualities, the different kinds of headaches that are coexisting and trying to understand what is happening. We know that migraine is more common in those with hypermobility spectrum disorder, being 30% of people with hypermobility versus 6% of men or 18% of women in the general population. It's not uncommon for CCI to trigger migraine, and we'll often see patients in a chronic low-level migraine state because the CCI is an ongoing issue, keeping the migraine alive. There's also often a separate primary non-migraine headache. This can present like a trigeminal autonomic cephalalgia, an occipital neuralgia. It can take on different qualities, and we really want to qualify what's going on in terms of what that headache feels like, what it acts like, what triggers it, and understand that. There can also be changes in CSF pressure, and you might have pressure-related headache with CCI. And then the other piece of this headache is anytime the neck is unguarded with CCI, it will often unmask the CCI. So the muscles usually attempt to hold everything together, but they don't always do that. And if you're caught off guard, things can slip, or as you're sleeping, things often relax. So it's not uncommon for patients to say they wake up with a headache or a headache wakes them up. Brain fog, fatigue is part of this. That can be related to the migraine. It can be to sympathetic chain effects downstream. Exercise intolerance or post-exercise brain fog also can be sympathetically mediated, can be due to vascular regulation. We know with brain injury, for example, there's impaired vascular tone control with exercise after brain injury. Is there a similar thing with CCI? Don't know, but we see exercise intolerance for sure. There's double vision that will often present, it's a convergence disorder. So the patient may say, they can read for a paragraph or two, but then the lines start to cross over. This is not blurry vision, it's more double vision, where the eyes just don't line up and focus on the same place at the same time. Blurry vision happens more with alterations in cerebrospinal fluid pressure, so intracranial pressure, the pressure of fluid inside the brain. And if there's obstruction of outflow of the cerebrospinous fluid due to the CCI, then you can have, increased intracranial pressure, which can cause blurry vision separately from the double vision. We'll often see TMJ dysfunction, and I say dysfunction very broadly because it can present a variety of different ways. But if C1-2 is unstable, that will affect the articulation of the jaw, and just the mechanics of the jaw are often thrown off when C1-2 is affected. Of course, neck pain, I put it in bold because obvious, kind of like the headache. And the neck pain can have a variety of presentations as well. Upright positional intolerance. This can be a little tricky because it can just be due to the instability. So sitting up at a computer, working at a computer for some period of time until headache gets worse, blurry vision starts, double vision starts, and then the patient will want to lay down and they'll feel better, and then they can get up and do it again for some set period of time, generally. Not always. Sometimes once it's triggered, then they need a day to recover. Dysautonomia, a big, broad category. Lots of practices are focusing just on dysautonomia as a diagnosis, but it's really a symptom. And it's important that we understand that there is generally a cause and we have to identify and treat the cause. Otherwise, the dysautonomia won't be fixed. Yes, we can use different medications to regulate the dysautonomia, try to rebalance the sympathetic and parasympathetic tone. But at the core, we have to figure out what's actually going on. And with CCI, there can be vagus nerve dysfunction. So as the vagus nerve exits the spine, there can be traction on the nerve, which can impair gastric motility. Gastroparesis is a common side effect of CCI, but of course, gastroparesis also happens with migraine. We really want to understand why these things are happening, and there may be more than one reason in any given patient. And then also we see sympathetic hyperactivity. Quite frequently, we see this as hyperadrenergic POTS. And the hyperadrenergic really just means that the sympathetic reflex response to the POTS is exaggerated, meaning there may be an excess tachycardia response. There may be a sweating, cold, clammy feeling. There may be a panic, anxiety feeling. And this can also happen spontaneously without the POTS triggering it. Screening for these symptoms, definitely part of it. And similarly, when we're treating CCI, we're looking for these things to get better if they're related or not. And then, of course, the things that we least want are motor and sensory symptoms in the extremities or in the face. And this is what happens when the spinal cord is affected or the brainstem is affected. You can have tremors, pins and needles sensation, alterations in reflexes, poor coordination, difficulty walking, things like that. That's when we really get more concerned and call Dr. Jenkins right away. Complications of craniocervical instability. Of course, if there's obstructed CSF outflow, then there will be increased intracranial pressure, typically blurry vision, whooshing sound in the ears, pulsatile tinnitus, nausea. There's often a position dependence. Things are better upright when there's increased pressure, worse laying down, worse bending the head forward, things like that. Spinal cord compression, which is basically what I just mentioned. Vascular compression, when the head moves forward, when the occiput rotates forward, there can be other structures that also move along with it that put pressure or tension on the jugular vein. If there is impaired jugular flow, that means blood is backing up into the brain. This can also increase CSF pressure, cause a lot of these same symptoms as CSF outflow. So part of the workup is distinguishing is there CSF outflow, is there jugular obstruction, or is there both? And then, of course, there can also be vertebral artery compression if there's adequate rotation of the vertebra. And of course, this can cause syncope, passing out immediately, or dizziness, imbalance. And it often is triggered with rotation. Glossopharyngeal neuralgia, this will happen if the styloid process is either turns too far stretched forward, too far forward. Basically, the glossopharyngeal nerve wraps around it. This will be like sharp stabbing pain in the ear or in the throat. Happens also with Ehlers syndrome, which can be pronounced or exaggerated because of the CCI. The positioning of the head relative to the neck has changed. We'll see dystonias, meaning increased involuntary muscle activity that causes pain, abnormal posturing, abnormal range of motion. We'll see this in the face with orofacial dystonia, and we'll also see it around the head-neck junction, cervical dystonia. And then, of course, there are compensatory postures which trickle down. So gravity pulls everything down and forward. So we'll see TMJ articulation affected by this. We'll see thoracic outlet syndrome. We'll see other neck pain. We'll see wear and tear on the facet joints in the neck in a pattern that's all downstream of the CCI. Our diagnostic workup. So this is where it gets interesting, and different providers have different approaches. I'm going to review things that are out there and sort of talk through them, and I'll give you some imaging examples so you can see them for yourselves. You may have heard of DMX. This is popular. This is live fluoroscopy. So basically, under live X-ray, they will have you move your head up, down, side, side, and rotate. And they'll look at it from different angles, and they'll look at the articulation of the OA and the AA and give you an answer. This is a lot of radiation. I do not order these. I do not do these because it is extensive radiation. And to be honest, I don't know that we need them. I think we can demonstrate it other ways with less radiation. Also, it's really hard to find. It's hard to find one that we'll get, and getting it covered under insurance becomes an issue. As routine practice, when I'm working up CCI, I will do flexion extension x-rays as well as lateral bending odontoid views. The odontoid view is where we're looking at the C1-2 arch, which is a pretty standard view. It's less standard to have the ear bent towards the shoulder with the mouth open towards each side to see if it's stable or if that space between the dens and the C1 arch moves. But that's what we're looking for there. We can also do a rotational CT to look at rotation of C1. Generally, we will just do slices from the occiput to C2 or C3 because that's really all that we're looking at. And this can also include vascular studies. So an angiogram, we're looking for arteries, or a venogram looking at the veins to see if there's active compression with maximal rotation to either side. So if someone starts to feel dizzy or they lose vision in one eye when they rotate their head, this is the study to see if that's occurring, because it can be done quite quickly because we don't want someone holding their head in that position long enough for an MRI. Also, MRA, MRV is not as reliable in vasculature that doesn't have a straight course. So in this area of the neck, head-neck junction, these veins and these arteries are curving about a good bit, and MRA, MRV is not as reliable for that as CTA, CTV. Now, seated MRI, this is another popular study with flexion extension. There's a lot of measurements that have been made and normals and abnormals determined that I would say is still in its infancy as far as science is concerned. Again, this is not something that insurance will always cover, and the interpretation of this is often broad. One of the benefits of this is we can look for CSF outflow obstruction. There's a specific sequence we can do for that in flexion extension. Even without the flexion extension, there may still be value in looking just for CSF outflow obstruction in the seated position, more so in the supine position. It's also helpful for looking at OA instability because it's related to that CSF, but we can also look at some of these measuring points. So over on the right, this is a CT, but it gives you an example of some of the measurements that can be examined to look for realms of what's concerning for stability and instability. And then, of course, vascular imaging. There's other vascular imaging that we can do, and there are venograms that are even more specific. So this is a standard flexion extension. Again, I look at this for anyone with neck pain and whether or not they have hypermobility. because I'm looking for evidence of micro instability. So if we look at C2, and Melanie, I don't know if you can use your pointer here, but in flexion, the C2 is ever so slightly anterior to C3. If you look at that posterior longitudinal line, so that's C1, go down one more, and you can see there's just inflection, there's just the ever slight anterolisthesis there. And then when they go into extension, it normalizes, if not pushing towards the back, and the C3 just below, and the C4 below, and the C5 below in extension, all retrolithes just a little bit. Now, is this something we would call a spine surgeon for? Absolutely not. But is this something that will trigger guarding of the neck muscles? Absolutely. Can it be responsible for pain? Sure. Does it increase instability of the disc and allow more wear and tear on the disc to occur over time? I believe so. If this is present in a patient and they have pain on exam at those levels, I will often diagnostically test these levels. And when these joints are filled with fluid and they're numb, if the neck muscles stop guarding, if their pain goes away, then that's evidence to me that they are the primary source of pain. And I will often offer treatment for these levels with regenerative medicine to tighten the ligaments. As far as academic studies go, there are actually 3 very small studies, but given that there are really no studies for hypermobility and regenerative medicine, I'm happy to have these 3. There are 3 small studies that looked at prolotherapy, dextrose prolotherapy, for dynamic spondylolisthesis and flexion extension, and they showed 50% improvement in the degree of anteroretrolisthesis on flexion extension after prolotherapy. So I use it. I've been using it for many, many years with decent results, and that's my general first go-to item. And of course, you can see the facets here. We're looking for facet-mediated pain, other things we'll look at too. And sometimes on the flexion extension, the space in the front between the C1 arch and the dens will also change on flexion extension. That also, we don't see it a lot, but it sometimes happens, which is a clue for CCI at that level. Here we have the odontoid lateral bending. And you can see on the left side of the screen, patients bending to their right side. If you look at the lateral margin of C1, you can see how it falls off the side of C2. Yep, and that's a pretty big gap. We'll call that a lateral listhesis. I'm very specific to get these without rotation because rotation confuses the picture. I just want to know if there's any instability there. The other thing we look at is the space between that articular pillar and the dens. And the space on the left is quite small. It's larger on the right. In the middle of the screen is the neutral. And even in the neutral, there's a little asymmetry in that space left to right. Also in the neutral on the left side, if you look at sorry, that's the right. On the left side is the right side of the screen, but the left side of the patient. There's a little bit of lipping on that facet end plate. So that to me means there is some hypermobility. There is some rubbing occurring there. That is a sign of degeneration. And in this particular patient who's 24, I don't expect to see that. So that would only happen if there was a prior trauma or if there's some excessive motion causing that joint to rub more than expected. And then, of course, on the right side of the screen here, we have the side bending to the left, which shows the same thing. You can see that lipping even more clearly there as on their left side, on the right side of the picture. Here's a rotational CT. So we sort of look, this is overlying the C1 and the C2. So you can see the degrees of rotation there from one to the next. The same thing, a picture on the right side, it's a compounded image where you can see the rotation there. And this is 3 different MRIs from 3 different patients. And these are standard supine MRIs. I just wanted to show you these to show you they have some utility. And there are things that we see here that are useful. Starting on the left, this is a patient with CCI proven through injection of C1 to that improved with injection of C1 too. But we look at this, and on the MRI, there's really nothing meaningful. Maybe Dr. Jenkins will have something to say about this, but when I look at this, I don't see anything meaningful. The radiologist didn't call out anything. The middle one, this is a patient who did not have positive lateral bending x-rays. They were fully intact. But posterior to the dens, there's a massive pannus or increased thickening of the ligaments of C1 that stabilize here. So this is concerning for autoimmune. And of course, there's a disc herniation lower down. That's less concerning. But Otherwise, I just wanted to point that out. And this is among the reasons why we get MRIs and look at all the soft tissues as well as the bony tissues. And this final one, this is another one that looks, we can talk about it. This screenshot isn't the best, but there's a little bony change at the top of the dens, and the space between the dens and the base of the cranium is a little decreased. And sometimes we'll see it where there's a little bony reaction between the top of the dens and the base of the skull, which means that in real life, there's some rubbing occurring there. The other thing is the space between the C1 arch and the dens here, it looks a little increased to me. And again, it's not a dynamic study, it's just a singular pose, so we take it with a grain of salt. And there's also a little bit of thickening of that ligament posteriorly to the dens, which, again, this thickening can happen with hypermobility, but it doesn't have to. And it can happen with autoimmune conditions. All right, here's a seated FlexX MRI. And I bring this, and this is done by a facility outside of New York City, but nearby New York City, and they're kind of known for doing this. But I pull this up to show a few different things. Number one, their lines and how their lines are drawn is not consistent from one image to the next. So the numbers that they produced on this screen are not exactly perfect. And I wouldn't make any hard and fast decisions based on these numbers. And again, these are also not heavily studied, reliable measures that prove one thing or another thing. Second thing, this patient has instability at C2-3, and you see it on the extension. And the extension at C2-3 is probably what makes the most dramatic change in these numbers. And assuming they had the lines drawn correctly, I think it would be more obvious. But I bring this up because this is a patient of mine who has both autoimmune C1, C2 degeneration and instability, most likely due to the autoimmune. All right, diagnostic workup. Testing that's not level specific, meaning OA versus AA. We will trial a rigid collar, such as a Miami J. We may trial cervical traction. Going back to the rigid collar trial, there are different protocols depending on who you speak with. Some will have patients wear it for a few days and see how they feel. Some will have them wear it consistently for 2 weeks and consistently for 6 weeks. It's often difficult for patients because it's rigid, it's uncomfortable, and often the patients have accustomed to a posture, meaning that the muscles and other structures around the neck have come to enable the persistence of that posture. So forcing them out of that posture or attempting to force them out of that posture through using the rigid cervical collar can be uncomfortable. It can put tension on the neck in places that cause new and different pain. They may not be able to tolerate the collar so easily. So there are limitations to using this technique, but anything that does improve with this collar is likely related to CCI. Anything that doesn't improve with the collar may or may not be related to CCI. It's hard to prove conclusively. The cervical traction, the image to the right here, there's non-invasive cervical traction, which is what this is, where basically the head is just pulled up. And while they're in that retracted state, what feels better? What doesn't feel better? It can be difficult, again, because this can also be uncomfortable for the patient. So they might be distracted by new and different pain caused by this. And they may not be able to clearly tell you what feels better in the moment while this is occurring. Also, they can't really move around and do things and live their day and give you really solid information. So it's of limited utility, but there can be information that we get from this. Also, it's not uncommon for patients to rebound after trial of traction. So basically, the heads up, everything feels good. Maybe their CSF is outflowing for the first time in a long time, and they're feeling actually pretty good. But then they release and they go back to normal. There's often a rebound of symptoms. So in my opinion, when we get that rebound of symptoms, that's almost more conclusive for CCI than just the improvement that they have with the traction, because a lot of things will feel better with traction. And then, of course, there's also invasive traction where screws are placed in the skull and the head is manually lifted up and decompressed that way. All right, diagnostic procedures. We can do a sympathetic chain block. So the sympathetic chain supplies the fight or flight response to the brain, controls blood pressure, tone, things like that into the head. As we said before, the sympathetic chain can be irritated from CCI, from the stretch injury, or from muscle tension, putting tension on it because it goes around the longus colli, which is one of the deep stabilizing muscles of the neck. Often that muscle is hypertrophied, it's enlarged because it's constantly stabilizing, can put tension on things. So sometimes we'll block the sympathetic chain to see what symptoms get better. Often many CCI symptoms will get better with this, but it's not CCI specific because there can be other pains and other symptoms that do get better with this block as well. But it's something that gives us a data point that we feed into it. We can do a C1-2 intra-articular injection. That's what the picture is on the bottom right. On the left side, you can see the needle actually going into the joint. On the right side, you see the red dot where the needle is placed to go into the joint. When I do this, what I do is I fill the joint with fluid to simulate stability. And I'm also using a very low concentration of lidocaine. The safety of this injection comes in it being so close to the vertebral artery and so close to the intrathecal space. The highest risk here is injection of lidocaine into either of these structures. So we try rigorously to avoid that. And we also, when I do it, I also use a very low concentration of lidocaine so that I'm getting a pain block, but I'm not using any more local anesthetic than is absolutely necessary to get the diagnostic outcome that we want, which is filling the joint with fluid to see how the patient feels. So if we have evidence of CCI, symptoms of CCI, and the patient wants to test C1-2, we have imaging evidence of C1-2, I will take them, we will do both sides C1-2, and we'll see how much fluid the joint accommodates, because a normal joint should only hold 0.3 to 0.5 mLs. Generally in patients with CCI at C1-2, I can get a CC. I've even gotten 2 CCs. I've had patients where I've put 2 CCs in the joint and it could have taken more, but I don't like to overdo it. So we stop there. And immediately after we do this, we have the patient sit up and we see how they feel. Any symptoms that are gone are related to C1-2. Anything that persists is not C1-2. And this is another situation where before we go and do this, any other thing that's causing pain in the head, neck, arms, I like to treat that first and get it out of the picture. If the patient's having constant low-level migraine, it's going to be difficult to know what's CCI and what's migraine. I like to get the migraine treated, get that out of the way. If there's another neck pain, anything I can treat first, I do that before we go and do this injection, just so the results are as clear and clean as possible. And then as far as the OA or C0, C1, we can inject that joint, but it's even a riskier injection than the C1, C2. And there's no good diagnostic CCI related test for that joint. So for example, I can't so discreetly fill it up and stabilize it temporarily like I can the C1-2. So essentially, when we know the patient has CCI from all of these other things, and we're trying to distinguish, is it OA, is it AA, is it both? I can inject the AA, the C1-2. We can see what gets better with that. Anything that got better with the collar that doesn't get better with the C1-2 is likely the OA. And then there are other symptoms that are distinctly OA, like if there is a C1 radiculitis. Other things that sort of fit more with the OA specifically, then we can understand that both are involved. So treatment, of course, treat the anatomy. Yes, we can go after the symptoms, we can try different medications, but we're really just palliating the situation. We're not actually doing anything that's going to help the long-term situation for the patient. So treating the anatomy. The least invasive is regenerative medicine injections. This is where I will generally start with prolotherapy into the C1-2 facet. We can do some of the surrounding ligaments. If they respond, great. If they don't, we can talk about PRP, just because some patients do not respond to prolotherapy. Platelet-rich plasma, that's where we draw your blood, spin it down, we take the platelets, inject them. They also stimulate a healing response. I generally don't start with platelet-rich plasma because I cannot include local anesthetic with that, and I like to have some diagnostic value from the local anesthetic to confirm that that is actually the place where you need it before we go and do something else. So I'll usually start with the prolotherapy, see if we get a response. Also, PRP is much more painful, and putting PRP up around the base of the head, especially if there's already some vascular issue or CSF outflow obstruction, it causes a lot of inflammation, which can worsen pain and headache from either of these conditions. So I don't jump to that. Surgical fusion, of course, if it's severe and there's no response to regenerative medicine options, that is the definitive treatment. And then if there is an underlying autoimmune condition, we absolutely have to treat the autoimmune condition. And I generally will get the autoimmune condition treated before attempting any injections. Of course, if the CCI is so bad patient can't get out of bed, they may require surgical fusion straight away. But if there's an underlying autoimmune condition, even that surgical fusion, the healing will be difficult, because the whole reason CCI develops after autoimmune condition is because there's autoimmune destruction of the connective tissues. And it's difficult for healing to occur even after surgery if the autoimmune is not controlled, especially with RA. So getting that treated is an essential part of it. And of course, treating the associated conditions, migraine, TMJ dysfunction, TMD dysfunction, the dystonia, dysautonomia, mental health. A lot of these things will get better when the primary issue is treated. Some of them we want to optimize before, but there's a balance, and we work through these together. And then, of course, rehab physical therapy. Patients develop compensatory behaviors. They learn to hold things together and react to keep things from getting worse. So there are learned patterns of motion that have to be unlearned. The muscles have to be retaught how to work appropriately. The guarding patterns need to be recognized, and things need to be changed and adapted. And that really can't fully happen until the primary instability is treated.
So hello everyone, my name is Melanie Carminati. I'm a physical therapist and the owner of Inspira Physical Therapy. I am excited this evening to talk about CCI and what physical therapy can do. I'll be focusing mainly on conservative preoperative physical therapy, but I will end with a very brief mentioning of what postoperative physical therapy would look like. So again, my name is Melanie Carminati, owner of Inspira Physical Therapy and Pilates. We see a large volume of people who have hypermobility spectrum disorders and or different types of EDS. And CCI, as we've mentioned in the other webinars that we've done, is a very common comorbidity that we see with our patients. And in previous webinars, we spoke extensively, or I presented extensively, about dysautonomia and management of that. So if you're curious about that, we can definitely send you that recording. I did go over some of the things that we do, but as Dr. Siefferman mentioned, dysautonomia is a common symptom associated with CCI, so we are managing both when we're in physical therapy and considering both. So again, this webinar is informational. It is not supposed to be individualized medical advice, so please follow up with a specialized healthcare provider. It does take a team when treating CCI and also treating the other comorbidities associated with EDS and HSD. I'm just going to speak briefly about some of the CCI type symptoms. We'll talk about physical therapy screening of CCI, some physical therapy interventions, and then other resources. So the screening process for CCI from a physical therapy standpoint, I very often mention Leslie Russick, who is one of the main physical therapy researchers for EDS and HSD. And this research article is what we rely on when we are trying to understand if a patient does have upper cervical instability, which they are using interchangeably for CCI. And following this flowchart, essentially, do we suspect this person has upper cervical instability based on the symptoms that Dr. Siefferman mentioned and some of the ones that you see that I wrote over here? Yes or no? Is there generalized joint hypermobility? And then just going through screening for yellow flags and red flags, and then determining what level of irritability this patient is experiencing. Because all different types of patients present differently when they have CCI, and some people are more severe in terms of the level of irritability, and some people are more mild. And that will determine what we can do in physical therapy from a conservative preoperative standpoint and what we will want to avoid. So for myself, this is just how I am thinking of things when I'm evaluating a patient. If they are coming in and they present like they have HSD or HEDS and that generalized hypermobility, I'm thinking, okay, does this person possibly have CCI, which is one of the comorbidities? And if they have that, then I'm going to be following up with questions about dysautonomia and POTS. When they're having dysautonomia and POTS-like symptoms with that heart rate irregularity, shortness of breath, fainting episodes, other things related to the autonomic nervous system, I will be monitoring vitals and just generally observing and making note of changes in the patient throughout the exercise or throughout manual therapy. So there's a lot of observation that's happening during physical therapy when we're working with someone who has CCI. Yellow flags. So according to the research study that I just mentioned, the yellow flags are more of the psychosocial factors that require support from psychotherapists, which is outside of my scope as a physical therapist. So many times we're just checking in with the patients and seeing if they already have the support that they need for managing anxiety, depression, panic attacks. And many times being able to weed out, are there POTS symptoms? Anxiety is, vice versa, is a challenge for many patients because it can mimic that, and or a POTS episode could bring on an anxiety attack. So making sure that someone has the proper support that they need for managing their POTS symptoms or managing any of those yellow flags is crucial. Red flags are when a headache is worse with Valsalva maneuver, seizure-like activity, altered consciousness. These are things that if I'm encountering with the patient in that very initial evaluation, I am making sure that I'm referring them out immediately for other workup, because they will not be able to proceed with physical therapy successfully unless they have other providers who are managing their care, because that is a sign that the CCI is more severe from my standpoint. Physical therapy interventions. So I do a lot of education with my patients who are hypermobile and who have upper cervical instability. And a lot of the education is just generalized, understanding what are the other comorbidities, what they can do to manage their symptoms, what are the triggers, and what is their plan in case they encounter an emergency. So we talk about these things over a course of multiple visits. It's not all just in one visit. We talk about self-care. We talk about when to wear a cervical brace. So if we are suspecting CCI, at some point we will also be recommending testing out a cervical collar. I have a slide coming up where I'll talk more about that. As Dr. Siefferman mentioned, posture and body mechanics education is crucial. So for all of the physical therapy, regardless if it's CCI, if it's pain in the shoulder, knee, back, whatnot, pelvic pain, if we are trying to treat someone as a whole, we want to be adjusting their mechanics, their posture, and making sure that they're stacking the head as a block, the torso as a block, and their pelvis as a block. We do a lot of pain science education as well. Being in chronic pain is something that requires, again, a team, and being able to understand the science of pain will help to reduce the experience of pain and reduce potential pain flares. Neck bracing, we'll mention it again in a little bit. Manual therapy, so depending on the level of irritability, if someone is mild to moderate, they will likely be able to tolerate manual therapy well. But in patients who have high irritability levels of CCI, they will not be able to tolerate manual therapy. So if you're someone, if you know you have CCI, or if you're not sure and you're thinking that some of the symptoms that we've mentioned sound like you, and you've gone for massage or you've gone for physical therapy in the past and they've done hands-on and your symptoms were worse, this would be more like high irritability category. So for those patients, we will be focusing more on external braces and supports, strengthening that is not irritating to the upper cervical spine, and then other functional re-educations in terms of movement. For motor control, we're always starting in neutral position, most of the time in supine. There's different eye movement muscle energy techniques that we use. Pelvic and lumbar stability, as I've mentioned in previous slides when we've talked about physical therapy overall for hypermobility and EDS, is where we always start. So lumbopelvic stability, you need to have that core strength. You need to have that hip strength, hip abductor strength. Everything needs to be firing in this deep core first, as well as being able to pull on diaphragmatic control. For people who are hypermobile, it's super common to have difficulty with diaphragmatic excursion. Let's see. So as I mentioned, we do Pilates in our office. The type of Pilates that we do is more of a rehab-based Pilates. And the Pilates equipment, specifically the reformer, is really amazing because it allows patients who have CCI and who have dysautonomia or hypermobility in general to strengthen and stabilize with resistance in a supine position and in a way that doesn't irritate their symptoms. So we do use the Pilates equipment a lot in our office, and many of the home exercises that we provide are Pilates based in nature. So besides that, we're doing thoracic spine mobility and shoulder, stability and strengthening as well. Okay, thanks for your patience, everyone. So lumbopelvic stability and posture first. For all patients who have hypermobility spectrum disorder and EDS, we're always working on posture, lumbopelvic stability, and diaphragm breathing first. Understanding how to stack the head over the torso, torso over the pelvis is crucial. As you see in these other images here, forward head posturing and different slouched postures will cause that lengthening and laxity in the ligaments, which we don't want to be promoting. And as Dr. Siefferman mentioned, this takes a lot of patience and persistence in re-educating your body, because people who are hypermobile develop compensatory movement patterns. And when I'm working with patients who have hypermobility and EDS, we are, talking about, okay, where should you be feeling this? Where should you be feeling muscle activity? And there's constant ongoing communication happening during the exercises so that the patient understands where they should be feeling muscle activity and where they want to pause and reset and start again if they're feeling it in a muscle group that we don't want to be using. So as I mentioned, high irritability may not tolerate any manual therapy. So if a patient has said in the past massages make them worse, or they feel more headaches, more dizzy, more unstable after manual therapy, we will not be going to that right away. Vital assessment is required, and because of dysautonomia, we're doing vital checks before, during, and after completion of the physical therapy appointment. In addition, as I mentioned, just general observation and that ongoing dialogue during physical therapy to notice how the patient is responding. Cervical collars. So for us, we typically recommend the soft collar for sleeping and then the Miami J collar during the day. There is a wearing schedule, and it really depends on what the patient, if they're in a flare, and how often they need to be wearing it. According to Leslie Russick, in one of her other research presentations, there's not a ton of specificity from a physical therapy standpoint about how often they should be wearing it. There's kind of different recommendations from different sources, but generally speaking, we tell patients that if they're experiencing a flare or they're experiencing more symptoms, to be using the Miami J collar. And then when they're sleeping, they can be using the soft collar. Upper cervical stability and proprioception with the laser head strap is a fun way to do that upper cervical stabilization and strengthening. It is something that we transition to after we've done standard VOR and COR exercises. So something to just know, if you're someone who has CCI, ask if you already have a physical therapist, ask your physical therapist if they have the laser strap. If not, this could be something that you could talk about, buying and then having them take you through exercises to use it with. So cervical ocular reflex and vestibular ocular reflex exercises, we do use these a lot because they help with proprioception as well as some of the subtle deep strengthening of the upper cervical muscles. So there are different VOR exercises, essentially keeping the eyes fixed, turning the head side to side. You can also do the head going up and down. There's a whole series of exercises that we take patients through, but it does make a big difference in the management of symptoms and reduction of flares. Referring out, as I mentioned, it takes a team, so I'm very often referring to pain management physiatry, neurosurgery. I typically refer to physiatry first and let the physiatrist like Dr. Siefferman do the referral to neurosurgery, cardiology, neurology. All of these providers are involved in the care of CCI. And as a final wrap up, if someone has had a cervical fusion, there are different phases of physical therapy that we take them through. Each surgeon is a little bit different in terms of when and how long they're going to be having that first phase, second phase, and third phase, but this is just a general understanding. First, you'd be in a protected range, then we would do strengthening and stabilization, and then it would be more of a return to function. So, in conclusion, CCI physical therapy treatments can reduce the impact of living with CCI by increasing cervical spine stability and enhancing the other systems that are impacted by excessive upper cervical instability. Working with a skilled provider is key. Thank you so much. I'll be turning over the mic to Dr. Jenkins momentarily.
Hi, good evening, everyone. Thank you for taking time out of your day. This is a passion of mine, and so it's a delight and an honor to be able to participate and to work with other empathetic doctors treating patients who need a lot of empathy. Many of whom have unfortunately been gaslit by their doctors and their families, even for problems that were previously pretty inexplicable. And so I've known patients who've come into my office and I've asked them about a symptom and they'll tell me, "Oh, I wasn't going to talk about that. All my doctors and family tell me not to even bring this up with you." And so this is a passion of mine. I always want to make sure I treat my patients the way I would personally want to be treated under the circumstances. So anyway, I'm Dr. Arthur Jenkins. Some of you in the audience may know me. Some may not. I'm a neurosurgeon by training, spine surgeon by specialist, a researcher by passion, father of three. I do what I do because I always want to make sure if the situation were reversed, I'd be equally happy with the outcome of whatever conversation, procedure, or whatever we're doing. And so I had not known anything about this during my residency. It was not on boards in any meaningful way. And I started having patients that would come into my office that were a real mystery. Fortunately, I like mysteries. A little background, it's a standard practice to describe your disclosures prior to beginning any meaningful talk. And so I am a spine surgeon. I do make money doing spine surgery. I think I do it pretty well. I'm also an investor in a couple of companies. I have my own company to try to prevent injuries and to help with surgical techniques, but I have no revenue from that yet. Concepts: be patient, be persistent, and be pragmatic. We can get you to a better place. As we've heard earlier, hypermobility syndromes, including Ehlers-Danlos Syndrome and others, including potential post-infectious syndromes, do damage the ligaments, the underlying stability of what holds the bones of the body together. And in particular, the upper cervical spine, where the head meets the spine, is one of the areas where we have some severe symptoms. But patients don't walk in and say, I'm suffering from craniocervical instability. That'd be an odd conversation to have. But they do talk about their brain fog, their headache, their passing out when they're standing up, or maybe not. Some of their seemingly unrelated or unexplainable symptoms that can be quite disabling. And in fact, in many cases, they're afraid to even bring some of the more disabling symptoms up, not just postural orthostatic tachycardia syndrome and the feeling like you're going to pass out when you stand up, but even sexual dysfunction, gastrointestinal dysfunction, urinary dysfunction, things that they can't explain. Nobody else can see anything on the standard MRI images, and they're just afraid of not being taken seriously. But if you know what questions to ask, they're usually more than happy to describe them. The fundamental anatomy has been reviewed already, but I think it bears a little bit of discussion because we're going to be discussing treatments that are specific to this area. And of course, the spine sits at the bottom of the skull. The spinal cord moves out through the middle of the spine and the middle of the bottom hole of the skull. And nerves, blood vessels travel through the skull to then travel within the neck, in and outside of the spine. And excess movement can put traction and pressure on these structures that live in this area, including the arteries, the veins, and the nerves that run in these areas. Now, the sympathetic trunk happens to be one area that seems to be very poorly understood, but everybody has one, and you need that balance. And that runs right up on the outside edge of the spine and goes up into ultimately terminates in smaller nerves that go into the brain. And then in addition to that, there are ligaments that hold the spine together, and they move in different angles depending upon where they are. And there are some ligaments that are actually especially suspect in patients with conditions like Ehlers-Danlos syndrome, or patients who have had trauma that has put excessive rotational stress on the spine. Some of these what normally are considered minor ligaments may be ruptured, and that may leave the head still attached but allow for excessive range of motion. But it's not a problem because you want to be more stable rather than completely unstable. The head falling apart is not a good thing. But in many cases, the standard imaging that doctors have been trained to do doesn't find those rotational ligaments to be disrupted because they're not studying in that position. So one of the other areas that often leads to problems is in what we call the stylocervical region. And that's the styloid process comes off the base of the skull. The C1 transverse process comes off the side of the first vertebral body in the spine. And the nerves and the jugular vein run in the space in between. And this is a more normal configuration, showing that there's plenty of room in between these two structures for the jugular vein to drain blood out of the skull, and for the sympathetic superior cervical ganglion, the sympathetic nerves, to run up into the skull. But in hypermobile patients, this isn't a normal situation. Now, the autonomic component of this, the nerves that include the balance between the cranial parasympathetic nerves and the spinal sympathetic nerves, is essentially the yin and the yang of the balance of these two sympathetic parasympathetic that make up your global autonomic nervous system. So autonomic dysfunction means something is out of balance. It could be an over or underactive, depending upon whether it's an irritation or a compression causing dysfunction of any of these nerves. So this can result in a broad spectrum of these symptoms, including from repetitive stress injury on the sympathetics. You can get cranial nerve dysfunction from the impact of one nerve on other nerves. You can have gastrointestinal symptoms because the vagus nerve and the hypoglossal nerve tend to control some of the gastrointestinal function. It can cause auditory problems, including hearing, sounds that nobody else can hear. It can cause headaches from a number of different mechanisms, not the least of which is the back pressure of the venous blood not being able to leave the skull, as well as cardiac symptoms from the regulation of the heart rate being dysfunction, either through sympathetic or parasympathetic imbalance. Now, jugular venous compression, we talked a little bit about that, can be both mechanical compression from those two stylocervical gap, and I'll show you what that looks like shortly. But it can also lead to stress, and just as a Chinese finger trap gets narrower when you stretch it, you can get stretching on any tubular elastic structure that you pull on, similar to stretching a water balloon, will cause it to get narrower. And then high brain pressure symptoms come from the backup, and that can cause all sorts of dysfunction, including real cognitive dysfunction, word finding difficulties, memory problems, as well as headaches and other forms of dysfunction. These tend to be in this condition something that does resolve with rest that takes the tension off of that vascular compression. But sometimes some of the symptoms are persistent. Now, the arterial system is also affected. And I've seen patients who have the carotid artery actually compressed and stretched by the head rotation out of place. But there's a well-documented syndrome called the bow hunter syndrome, which is from an archer pulling their head, and they turn their head 90 degrees to look down their arrow. And if you hold that position and you're hypermobile, you can actually occlude your vertebral artery. You can cause a stroke if you're not careful. So these are well-documented conditions that have not previously been well associated with each other. And so patients tend to get gaslit if a doctor isn't thinking of putting this all together into one syndrome. Now, the symptoms that patients have, I find, are critical to understanding the patient's specific pathologic situation and the treatment strategy. And Dr. Siefferman mentioned a little bit about that. The way I think about it is the patients who have more problems in head going forward or backwards, it's more of a occiput to C1, the first motion segment problem being most dysfunctional. And they may have pretty normal C1-2 function, and therefore they have less rotational problems, or it may be the other way around. Or, like many of my patients, they have both. And sometimes we even see patients have more one set of symptoms going into an operation. We only treat that one level, and then the other level becomes symptomatic from new stress being put on it. So it is important to tease out all of these factors and understand the whole spectrum of where are the greatest stress to the neurovascular system, and make sure that we're adequately and sufficiently planning a treatment strategy. And so one of the things that this looks like, here's an actual patient scan. And what we're seeing here is that first, there is often an anterior translation of the skull forward on the spine. And then there is rotation forward. There's a kyphosis. There is this increased atlantodental angle. The clivoaxial angle where the head actually tips forward more than normal. And then that causes this styloid process to be tipped further down towards the C1 transverse process, which then occludes the veins, the jugular veins, blood trying to carry blood out of the head, so that the pressure backs up into the skull. So one of the unfortunate side effects is that patients tend to be hypermobile. They tend to be hypermobile in much of their body. And so there may be other hypermobile associated syndromes that may need to be teased out of the symptoms that are present from CCI, so that we're aware that treating the CCI individually may not treat these other symptoms to manage these expectations. And sometimes you treat the biggest problem, the other symptoms don't feel as bad. And sometimes you treat the biggest problem, and now the other symptoms become more affected because now you're more active, or you're doing things you weren't previously doing, and you're stressing the other system better. So we don't always know the ultimate impact of what we do, but we certainly are here. And as long as we understand what to expect when you're expecting treatment, we can go through this process together. And so there are many other issues. One of the things that I find, and I know many of my colleagues might see a diagnosis of fibromyalgia, psychiatric disorders, or functional disorders, and say, oh, I don't want to treat that patient. They're not going to get better. For me, it actually piques my curiosity, because I know so many patients with EDS, CCI, and other conditions have been misdiagnosed with these buzzwords. And they do improve when you actually treat the underlying problem. And so this is another form of medical gaslighting. And so I do my best to actually dig in when others break them down. We look at, well, which symptoms are triggered by which movements, by association with other symptoms. When you get this, do you also get that? That tends to help us to link the two together and hope that treating one will make the other feel better. And then we separate out so that you know what to expect from the treatments and what not to expect. So the way I look at these things is I'll then dig deeper into, we'll order the necessary tests, and we'll be looking for what's going on with the jugular vein, what's going on with the styloid process, what's going on, and looking at it from different angles and understanding the proximity issues. Here's a patient whose styloid process is very close to their transverse process. Here's a patient whose head is tipped very far forward in that clivo-axial angle. And we often see, and Dr. Siefferman asked me what I saw on that study that was read as normal. And what I saw was there was actually a very big gap between the C1 posterior arch and the back of the skull, the foramen magnum. When I see a really large gap here and a tip forward here, that to me says this is not a normal position. And this suggests hypermobility tipping too far forward. We also can see that this clivus tip here is very close to the dens. It's not supposed to actually be touching, nor is it really supposed to be sitting right over this front edge here. It really should be sitting more here and tipping up this way. So these are the things that I look for. This is the rotational CT. Many of my patients have wondered, why do you have to scan me looking left and looking right? Well, if one part of your spine is looking this way and another one is looking this way, you make the angle, you can see they really do make a difference. And so this is actually the front of this body. This is C2, and it's supposed to be, or it's oriented this way. And this is oriented. So that's a huge angle here. And that is very helpful. Because when we document the abnormalities, it makes it easier to convince an insurance company to pay for this. So the surgical treatment options, and this isn't a technical how to do this, because I don't want any of you trying this at home, but we either fuse the relevant abnormal levels to stop the motion that's leading to the worsening of the symptoms. Another option is to go in and remove whatever the structures, like the styloid process, the C1 transverse process, or the digastric muscle, which we'll get to in a sec, if those are contributing to the narrowing. And the third option is to stent or balloon the jugular vein open to give it a little bit more flow to prevent that vascular insufficiency that leads to the increased brain pressure that's intermittent. Having permanent occlusion of the jugular, or partial occlusion of the jugular vein, does lead to a different condition called idiopathic intracranial hypertension, which leads to very similar symptoms, but because it's unremitting, it can cause severe permanent nerve damage because of the permanent high pressure. That's obviously a much more serious condition. Not that EDS and hypermobility isn't serious. So, did you say fusion, Dr. Jenkins? That's a scary word. Why would you wave that word around? You seem like a nice guy. Why would you threaten to fuse my spine? I'm going to be like Frankenstein afterwards, right? Well, truly, we don't have another operation that makes the spine normal, stable. We only have the ability to provide complete stability at one or more levels. And so we try to judiciously use that of one or two, the most affected levels of the 8 motion segments in the cervical spine. So we're not taking away all your range of motion. We're only taking away the top 2 of 8, leaving you the other 6 to do with whatever you're doing. And the odds are, if you are hypermobile to begin with, you're already moving more than everybody else in your peer group. And so even taking away some of your range of motion, you still have pretty normal range of motion afterwards. And then generally this follows the ancient medical adage, if it hurts when you do that, don't do that. So if it hurts when the top 2 levels are moving, stop them from moving. There may be consequences to doing these. Some patients do develop additional stress on the adjacent levels, but I would rather do that and deal with those down the road than make you continue to be miserable and untreated in the meantime. So this is what this looks like radiographically. The top one is just the top level, screws in C1, screws on the skull plate. Second one is screws into C1, screws into C2. And then the third one is screws into C2 and a cable at C1. And so these are each tailored to the individual patient and what we think is the least invasive but most effective way of having an impact on your quality of life. The other treatment, as we mentioned, one of the other treatments is resection, where we come in from the front to actually remove the styloid process, and if necessary, the digastric muscle, which if it goes across the jugular vein and the nerves in this area, causing increased pressure in the region, we can take that. It's considered a minor muscle of chewing, not a major one. So taking it doesn't cause any permanent damage. And then the third way that we approach this, and from some of the people I've spoken to, this is really best done after we've done one or two or both of the other two, and then treating any residual jugular venous stenosis, either by putting a balloon through, from outside the body and snaking it up into this space, ballooning it open if there's scar that's holding the jugular vein to not be able to fully re-expand, which happens sometimes, or putting a stent across it to hold it open if you think that maybe the hypermobility has led to weak enough soft tissue that there isn't enough inherent tension to hold it open. So fundamentally, surgical stabilization, the fusion procedures that I do, tend to improve patients' symptoms. So far, all of our patients have had some improvement in their symptoms, and in many cases have been able to get back to more meaningful lives. But there are different approaches to how people do that, and some of that is still the art of the practice of medicine, even among EDS knowledgeable and experienced doctors. We sometimes disagree on the perfect way of approaching every single patient. And that may be because of specifics of our personal experience and what we think works. But this is a review of some of our research. This is a little bit more of what you'd see in a typical medical presentation. And you can see that we do see that all of our patients do see improvement, not just in their head and neck pain, but sometimes in their back and leg and arm pain as well. So there is value to treating the neck first. And don't be afraid to ask for help. There are entire Facebook communities for support. The biggest one has 41,000 members, but they are literally hundreds of Facebook communities for people suffering from EDS. And you may find one that appeals to you in particular, or you may join several of them. And I suspect that some of these have multiple members. One of the problems I've struggled with, and I'm sure Jason can talk about this, and I'm sure he and his people and Melanie and her people have also struggled with this, is insurance doesn't really recognize this entire entity. The dysautonomia, it's very hard to convince them, and that's why we need to go to the trouble of doing all the tests that we do and getting all the documentation and fighting and fighting and fighting. So you do need help. Sometimes they'll pay, but most of the time they'll say no. Because let's face it, right now insurance companies are not in the business of providing care. They're in the business of collecting premiums and denying care. In fact, BlackRock, a big major investment firm, owns 10% of United Healthcare. They are suing United's CEO because after one of their other CEOs got shot, they started paying out premiums and their profitability went down a little bit, or paying out claims, because I think they were afraid. But he sued them saying, you've got to stop. We want more profit. We don't care about patients. We want profit. And I think that's just, I mean, it's one thing to think it. It's another thing to actually file court papers demanding it. So this is a real problem. And it requires, like I said before, be patient, be persistent, be pragmatic, understand what you can get and get it to help. You don't expect cure, but do expect help is on the way, and don't give up. And that surgical treatment can be beneficial if you've run out of the options that Dr. Siefferman and Inspira can provide for you. So I want to thank you all for your patience, including the patience with the technical issues that we've had here today. I'm certainly disappointed that you didn't get to hear from the patient herself what an impact surgery can have if you get that far down the road. But if you have any other questions, please feel to reach out. On the left side of the screen is a link to my YouTube channel where I have a couple of other videos similar on this particular subject of craniocervical instability. On the right side is for my website in general. And if you want to just grab a screenshot and save these social media tags and my website to type it into your search bar, it's just jenkinsneurospine.com. But, we get it. This is not an easy problem, but, that doesn't mean you're not worth finding a solution. So good luck. And I think we have a little time for some questions.